Welcome everyone. Today we are talking about stroke. It is very common in the emergency department. You have to know very much about it. Stroke is defined as sudden onset focal neurological sinus. It should be presumed to be vascular in origin. It means there might be obstruction or rupture of an artery. It lasts longer than 24 hours or causing death. Stroke is very common and is very fatal if not treated urgently. It accounts for about 11% of deaths and is significant cause of morbidity. I mean, the patient will end up with long-term neurological deficits and disability. Stroke can be classified as ischemic, in which there is obstruction of the artery. This is more common, 85% of cases, or could be hemorrhagic, which is due to rupture of an artery. The ischemic stroke can be thrombosis, can be embolism, can be small vessel disease, or can be due to shocks. There will be hypoperfusion. Rarely, it might be due to venous thrombosis, in which there is dural venous thrombosis, especially in pregnant ladies, those with hypercoagulable state or sickle cell disease. Could be also due to carotid artery dissection. The anatomy of the blood supply of the brain is very important to know about stroke. So the clinical features of stroke usually reflect which artery being involved in the stroke. For example, we have anterior circulation and posterior circulation. The anterior circulation is served by the internal carotid artery. So this internal carotid artery, the main branch, it will supply the middle cerebral artery, which is the commonest artery being involved, and also anterior cerebral artery. So anterior and middle cerebral artery compose anterior circulation. This will supply 3/5 of the cerebrum. Why it's important to know? Because anterior and middle cerebral artery, if obstructed, it will cause contralateral motor deficit mainly. So for example, if the stroke is on the right side, there will be motor deficit in the left side, or sensory deficit in the left side. At the same time, there might be other sinus symptoms like expressive dysphasia or neglect, in which the patient not looking at you, looking at one side. Something else is also important in anterior cerebral artery. In anterior cerebral artery, the weakness is more in the legs than in the arm, while in the middle cerebral artery stroke, the weakness is much more in the face and arm than in the leg. While the posterior circulation is supplied by the vertebrobasilar arteries. So these vertebrobasilar arteries supply 2/5 of the cerebrum, part of the cerebellum, and also brainstem. So if the patient have posterior cerebral stroke, usually they will have visual disturbance, contralateral hemianopia, sometimes disturbed memory. In cerebellum, if cerebellum is involved, the patient will have intention tremor, nystagmus, ataxia, vertigo, dysarthria, diplopia. Brainstem is also very important because most of the cranial nerves are there and the origin is there. So if brainstem is involved, there will be a lot of cranial nerve deficits. And there might be also motor deficit at the same time. And the brainstem stroke by itself might lead to unconsciousness. The basilar arteries gives the posterior cerebral artery. Anyhow, the anterior and posterior circulations are linked via posterior communicating artery, forming the So this is the anterior circulation, supplying 2/5 of the cerebrum, and this is posterior circulation. The anterior and posterior circulation are both connected via the circle of Willis through the posterior communicating artery. How you recognize stroke? There are some commonly pre-hospital medicine, emergency medicine tests like FAST, or also in the emergency department you may use Rosier in order to recognize them. In the FAST is usually used by the ambulance and non-medical people. General people can know it. For example, facial asymmetry. If facial asymmetry, the patient receives 1 score, arm weakness receives 1 score, speech difficulty receives 1 score, and you have to call the emergency department the ambulance as soon as possible. The Rosier scale is designed to be used in the emergency department. It has 2 negative predictive symptoms. So if these symptoms are there, it means that it will decrease the possibility, and 5 positive predictive symptoms. So what are these? The negative predictive symptoms are loss of consciousness or syncope. So the patient will have a negative point. Seizure activity, patient have -1. The positive one are asymmetrical facial weakness, arm weakness, leg weakness, speech disturbance, visual field defects. So each one the patient receives a positive score. So stroke is likely if equal or more than 1. 1 and more. In the absence of hypoglycemia, it means 93% sensitivity and 83% specificity, the patient have a stroke. What are the investigations? The main investigation, the first one that you do is a blood sugar. A random blood sugar is an easily useful bedside test, which sometime if the patient is hypoglycemic, have neurological deficit, that's why you have to do it as early as possible. The next investigation is CT scan. The CT scan, non-contrast CT scan, is most commonly used brain imaging. Most likely you have to do it to find a normal CT scan. It means that this is a ischemic stroke. If you find this, it means that the patient is having hemorrhage. However, the sensitivity for detection of ischemia is low in the first 24 hours. So in the first 24 hours, unlikely you see this ischemic lesions. Some hospitals, they may also offer MRI because it provides greater sensitivity and specificity. Another investigation that you might do if the patient is on anticoagulant, especially warfarin, you may do clottings like PT and INR. So you do it in order, if the patient have high INR, you use reversal agents like fresh frozen plasma or other things like prothrombin complex concentrate. ECG just to find the cardiac origin of thrombus, example AF. ESR, especially in young people with stroke, you may suspect vasculitis. So you may send ESR and other inflammatory markers. Other investigations like full blood count, urea electrolyte, lipid, chest X-ray. It should be requested, but unlikely to alter the acute emergency department management. It will not affect the management of the patient. So what are the proven benefits? What are the acute treatments with proven benefit? The treatments that are effective. First, admission to a stroke unit. A stroke unit will have a specialized doctor and specialized nurses that know the complications and specific treatments for stroke. Administration of IVTPA. So the IVTPA actually is indicated if the patient presents within less than 4.5 hours of the presentation. Antiplatelet like aspirin, or if contraindicated, clopidogrel. Surgical decompression. If the patient have massive cerebral edema and signs of increased intracranial pressure, you may consult neurosurgeon and they may do hemicraniectomy in order to release the pressure, because more pressure might cause brain death. So coming to the thrombolysis, nowadays we are using thrombolysis in patients who are having ischemic stroke with absence of contraindications to thrombolysis. When they come within less than 4.5 hours, we use the actylase mainly. Although tenecteplase can also be used and provides a lot of benefits, but what we have is alteplase. The alteplase, the dose is 0.9 milligram per kg. The maximum is 90 milligram. You have to use 10% as a bolus and the rest over 60 minutes. So you use it over 60 minutes, but use it 10% of the calculated dose over as an initial bolus dose. Alteplase can have short-term effects, but usually it reduces long-term disability. The earlier alteplase is given, the greater benefit the patient receives. But alteplase does not improve the survival. It means the mortality rate is the same when you use or not use the alteplase. The main concern for administering the alteplase is potential for getting the intracerebral hemorrhage. About 6% of people may get hemorrhage. That 6% might be minor hemorrhage or might be a major hemorrhage which cause death of the patient. But anyhow, this should be the patient. You have to gain consent from the patient or the family of the patient. The benefits are about 35% of patients may get benefit, not all the patients. Other emergency department management, if the patient have contraindication or delayed, have contraindication to alteplase or delayed more than 4.5 hours, you have to start with giving antiplatelet, which is aspirin. You give 300 milligram aspirin, you have to tell them that they continue for 2 weeks, or according to the neurology consultation. If the patient has been given alteplase, you have to delay aspirin up to 24 hours. Before giving aspirin, because it is oral, you have to tell them to take some water. If they cough or they have hoarseness of voice, then you have to insert an NG tube and give the aspirin through the NG tube. Many patients with stroke have swallowing impairment, so they have to receive the drug through the NG tube because it may cause aspiration pneumonia if without NG tube. If the patient is allergic or intolerant to aspirin, you can use alternatives like clopidogrel, 300 milligram. Sometimes, if the stroke is minor, we have a scoring system called NIHSS, which should be calculated for every patient. If the scoring system is less than 5, it's minor stroke. Neurologists tend to give aspirin and clopidogrel together. So these are specific conditions. They should be decided by the neurologist. In the emergency department, you have to maintain hydration, giving IV fluid, normal oxygenation, normal temperature, normal blood glucose. So you have to maintain these issues. So as a summary, stroke is a sudden onset focal neurological sign of presumed vascular origin that is more than 24 hours. Stroke can be classified as ischemic or hemorrhagic, and the clinical features can be recognized by fast or rosier. Usually clinical features reflect which vessel is occluded. And the proven benefits of acute ischemic stroke is admission to a stroke unit, giving thrombolysis if within time, giving antiplatelet and surgical decompression if there is increased intracranial pressure. Coming to hemorrhagic stroke, in hemorrhagic stroke, usually such patients have headache, vomiting, increased intracranial pressure. So some of them, they have very minor hemorrhagic stroke. So you have to do an ABCD approach, then admit in the hospital. If the patient is unconscious, you admit in the RCU. You may intubate the patient. If there are signs of increased intracranial pressure, you may give mannitol. You also prevent the increased intracranial pressure by preventing cough, by preventing vomiting, by also preventing constipation or urinary retention. So you may insert a Foley catheter, give antitussive, give anti-vomiting agents to relieve constipation. If the blood pressure is more than 180 over 120, then it means that you have to reduce it by labetalol, or you have to reduce it by IV antihypertensives. If the patient have subarachnoid hemorrhage, subarachnoid hemorrhage like this, which has a frog-like or spider-like sign on CT scan, then you have to use nifedipine. Nifedipine is a calcium channel blocker which only used for subarachnoid hemorrhage to prevent vascular spasm, and the dose is 30 milligram 2 by 6, 2 tablets 6 times per day. It should be taken for up to 14 days, which is the time when the patient is liable to get vasoconstriction. You have to consult neurosurgeon. Neurosurgeon looks at the hemorrhage. If a hemorrhage is at periphery and easy to and has causing pressure-like symptom, they may do surgery and craniotomy for them. So these are some examples for antitussive like dextromethorphan or awanilin. For vomiting, you may use metoclopramide, placil, ondansetron, zofran, prochlorperazine, stimetil. So these are the trade names, and these are the scientific names. For constipation, you may use bisacodyl, either suppository or oral. The dose is usually 5 to 10 milligram. Glycerin suppository, you may use lactulose syrup, 10 ml by 3 or by 4. Of course, lactulose is not good for patients with diabetes because it may increase the glucose level. Sodium phosphate enema. So this is enema used by patients. Usually it has such a shape of a bottle, and the patient should receive it and cause and improves any constipation which caused by stool impaction. Urinary retention, you use a Foley's catheter. So these drugs for vomiting can be used IV or IM, can be used 3 times daily, and the prochlorperazine, what's available here is usually IM, although internationally IV also is there. Prochlorperazine is usually used for patients with vomiting plus vertigo. So patients with vertigo, they gain more benefit from stimetil than other drugs. Coming to transient ischemic attack. Transient TIA is defined as a stroke sign symptoms that resolve less than 24 hours, within the 24 hour. There is an obstruction, then relieve it. According to the last NICE guideline in April 2024 updated, they say that all patients with TIA should be immediately started with aspirin 300 milligram. This is one. Previously, they were using a scoring system called ABCD2. This scoring system was used to assess the risk of subsequent stroke and referral, the urgency of referral. For example, if the scoring is low, they have referred the patient within 1 week. But if the scoring is high, they say you have to return to the hospital within the first 24 hours, or they admit the patient. But nowadays, they say do not use this scoring system. Every patient should return as soon as possible within the first day. Do not do CT scan. Actually, patients with TI no need to do CT scan unless there is clinical suspicion of alternative diagnosis which could be detected by the CT scan. Patients with crescendo TIA, like 2 or more TIAs in a week, should be admitted in the hospital and should be seen as soon as possible. Measures for secondary prevention is important. So once the diagnosis is confirmed that this patient is having TIA, if the patient has dyslipidemia, give lipid-lowering agent like statin, give antihypertensive agents, give treatment for diabetes, and management of AF, and lifestyle advice, example, smoking or obesity. So patients who are discharged in the emergency department should be advised that they cannot drive for up to 1 month. Then they may resume driving after this period if the clinical recovery is satisfactory. Some investigations might be done as an outpatient or even inpatient, example ECG, but the neurologist should order ECG, carotid Doppler, and echocardiography. This is to find the source of the emboli. Other basic investigations can be done like lipid profile, complete blood count, liver function, renal function, and electrolytes. So a TIA is a brief episode of neurological signs and symptoms that caused by focal brain or retinal ischemia, and substantial risk of stroke exists in the early period of TIA. In the first 24-48 hours, the patient might get another stroke or might get stroke actually after TIA. Early specialized assessment and modification of risk factors like diabetes, AF, hypertension, hypercholesterol, smoking may reduce the risk of getting subsequent stroke. Aspirin should be immediately started unless there are contraindications. And patients with TIA affecting the anterior circulation and who are potentially fit for surgery should have carotid imaging. So the carotid imaging can tell you whether the patient needs carotid endarterectomy or not. For patients with ischemic stroke, there is a lot of debate about how to manage the blood pressure, but most of the guidelines tells you that if the blood pressure is more than 220 over 120, then you regard this as emergency hypertension. Then you have to give IV drugs, example labetalol, to reduce the blood pressure as soon as possible. If the blood pressure more than 180 over 120, I mean it doesn't reach, it is high but it doesn't reach 120, then you have to reduce it by oral antihypertensives. If the blood pressure is less than 180 or over 120, then do not offer antihypertensive. You do not want to reduce the blood pressure, because reducing the blood pressure, if it is less than 180 over 120, it means that you expose the patient to more ischemia. So this is for ischemic stroke. But for hemorrhagic stroke, you have to reduce the blood pressure if it is more than 180 over 120. In some guideline, they say any blood pressure more than 160 should be reduced by IV drugs. Although what I said is also have some controversy, but again, this is as a general guideline. As a summary for all of that, any patient present with focal neurological deficit, you have to do ABCDE for them. during ABCDE, you have to do a random blood sugar for the patient. Then you do CT scan for the patient. In the CT scan, it might be ischemia, you give alteplase, or if more than 4 hour, you give aspirin. Or if it is hemorrhagic, you have to prevent increased intracranial pressure and consult neurosurgeon. Then you have to decide whether you put NG tube or not. So do a swallowing test. If the patient is unable or a swallowing test is impaired, then you have to insert an NG tube. Patients who are unable to walk to the toilet, you have to also put a Foley's catheter, or if the patient not agree, you may put a condom catheter. Thank you so much. I hope that you have enjoyed the stroke management.